the expert. As immediate past divisional director for musculoskeletal, digestive diseases, major trauma and perioperative care medicine, Dr. Mata has focused on promoting clinical excellence through collaboration, implementing programs that have led to the increases in both efficiency and care quality, and leading the development of the East of England Major Trauma Center and Trauma Network. Dr. Mata has held leadership roles in a number of UK and international medical societies, including President of the Neuroanesthesia Society of Great Britain and Ireland and President of the Society of International Neuroanesthesia and Critical Care, and has served on the editorial boards of the Journal of Neurosurgical Anesthesiology and Critical Care and the European Journal of Anesthesiology. The author of more than 80 peer-reviewed publications, Dr. Mata regularly participates as an invited speaker and lecturer at international events including the Royal College of Anesthetists, the European Society of Anesthesiology, the American Society of Anesthesiologists, Arab Health, and is a key collaborator with the Middle East Technology Summit and Middle East Patient Safety Movement. Let's give our warmest welcome and a big round of applause to Dr. Basil Mata, Senior Medical Director at Massimo International, Consultant in Anesthesia and Neurotrauma Critical Care at Cambridge University Hospitals Trust, Associate Lecturer at University of Cambridge, Cambridge, United Kingdom.
Good morning. My name is Basil Mata. I am the Consultant in Anesthesia, Trauma and Critical Care at Cambridge University Hospitals. I am also the Senior Medical Director for Massimo International. It gives me great pleasure to be talking to you about protecting the brain and how we can do this by optimizing sedation and ensuring oxygenation. First of all, I'd like to thank the Philippine Society of Anesthesiologists and the Philippines Medical Association for inviting me to speak. Dr. Carl Matthew, the Chair, Committee on Continuing Medical Education, Dr. Edgar Simon, the President of the PSA, all of you obviously for attending, and Massimo for sponsoring this session. I would like to declare that I am the Senior Medical Director for Massimo once again, and that I receive financial support from Massimo. Now, I have spent the last 20 years caring for patients who have suffered a brain injury at Cambridge University Hospital. This is our campus. And as I get older, I would really like to spend the next few years preventing healthy brains from getting injured in the first place. Now, we talk about monitoring the vital organs in anesthesia and critical care. Well, we're very good at doing that. We're very good at looking after the heart, the lungs, the liver, the kidneys. We monitor those extensively, preoperatively, intraoperatively, and postoperatively. The one organ that is the target in our anesthetic practice and in ICU, where our anesthetic drugs and techniques primarily work, and which is the most difficult to heal and possibly impossible to replace, is the least monitored. We monitor less than 5% of brains of those patients undergoing general anesthesia or sedation in intensive care on average. And the brain is at risk, not just in neuroanesthesia and neurocritical care. The brain is at risk in general anesthesia, all types of general anesthesia, in ICU, and in a variety of other situations. Now, when you talk about monitoring the brain outside neurointensive care and neuroanesthesia, it's not uncommon to hear your colleagues saying, I'm not a neurospecialist, I don't look after brains, I don't know how to do this, it's too complicated, and the benefits are not proven. Somebody once told me it was a distraction looking after the brain under anesthesia. And the common thing is that we feel we do okay, so quite simply, this is not necessary. But really, we're beginning to realize that that is not the case. We're beginning to realize that the brain is at risk in a variety of situations where we think it wasn't at risk. And really, protecting the brain is everyone's job, not just the job of those in neuroanesthesia and neurocritical care. Now, let's just think back why we give a general anesthetic or sedate someone. Well, generally speaking, we do that because we want to provide comfort for the patient. We don't want them to be distressed. We don't want them to be aware. We want them to tolerate the tube, allow us to ventilate them, maybe improve surgical access by allowing muscle relaxation use, improve vital functions in the ICU, ventilation, surgical condition, status epilepticus, and traumatic brain injury. But we have to remember that anesthesia and sedation are not the treatment. They're not the treatment. It's what we do to allow us to give the patient the required treatment. And what are the hallmarks of a successful general anesthetic? Well, a reversible loss of consciousness with lack of movement, unresponsiveness to painful stimuli, lack of awareness or recall of the surgical intervention. What we consider to be inadequate general anesthetic? Intraoperative awareness with recall. You know, it's most commonly due to underdosage. It's very, very rare, but it's the one thing that we all are worried about. Prolonged recovery, which is much more common than awareness, and increased risk of postoperative complications such as POD, postoperative delirium, and postoperative cognitive dysfunction, which are very common. And we all understand that getting the balance right is sometimes difficult. So let's have a look and see, what do we do? How do we monitor anesthetic depth on the brain? Well, what we tend to do is we tend to monitor anesthetic delivery. So we look at MAC, for example. Half a MAC of volatile anesthetic agent should prevent awareness. So we measure the anesthetic concentration we are delivering in the lung. TIVA, we use the predicted plasma and effector site concentrations. So we simulate the concentration we see when we give intravenous drugs. We don't actually measure it. So some of you might say, so what? So actually, we do not know exactly and accurately what anesthetic concentration is reaching the brain at any time throughout the surgical procedure unless we monitor it. In other words, we measure the predicted or the lung effect on certain drugs and not the drug effect at the site of interest, which is the brain. And hemodynamic parameters, as we know, such as the blood pressure, the heart rate, don't really adequately reflect the depth of sedation. And recall of surgical interventions, as alarming as it is and as distressing it is not the only important thing when it comes to monitoring the depth of anesthetics. Now, the Association of Anaesthetists of Great Britain and Ireland has just published its updated its guidelines on monitoring during anesthesia and recovery for May 2021. And interesting that they've put a section on the processed EEG as a depth of anesthesia monitor. Their suggestion is that it will aid the anaesthetist in adjusting the dose of anesthetics being given to an individual patient, and it may reduce the incidence of adverse effects resulting from either inadequate or excessive anesthetic dose, such as awareness under general anesthesia, postoperative delirium, postoperative cognitive dysfunction, and may improve recovery times. So the recommendations really, although they don't go far enough, they go a good distance towards reminding us of how important monitoring the brain is. So processed EEG should be used when TIVA is administered together with neuromuscular blockade and should be considered when TIVA is being used alone. There may be a role for processed EEG monitoring in the reduction of awareness in general anesthesia patients receiving inhalational anesthetics. The benefits of processed EEG monitoring resulting from reduced administration of excessive anesthesia are likely to apply irrespective of whether a neuromuscular blocker has been used or not. And we're reminding us that anesthetists should not rely solely on index value. So shouldn't use just a number like a BIS number or a PSI number as the only index or the only value in processed EEG. You know, we need to be more adept. We need to be more understanding of the EEG waveforms and being able to interpret them, being able to look at power spectral analysis and DSAs and relative band powers. So that is really a departure from just looking at a single number. Now, oversedation in the ICU is very, very common. And it's not unusual because we are afraid that the patients will be aware, they'll be too light, they will self-extubate. And especially in this COVID crisis, what we have seen is that this is a disease that is rapidly spreading, infecting a lot of patients, infecting our healthcare workers. So we were even more reluctant to let the patient be too light. So what happens when you oversedate the patients? Well, you get longer ICU stay, you get more myocardial depression, you get increased mortality, you reduce the number of ICU beds available, You reduce the number of drugs and sedatives and inotropes and pumps available. So really, excessive profound sedation was a problem in mechanically ventilated patients before COVID started, and it has been really exacerbated by COVID. And it's okay to monitor sedation in the ICU using a RASS score. Most intensive care units have got some form of sedation monitor, such as the Richmond Agitation and Sedation Score, the RASS score. And what we want to be is see the patient at 0 or -1 and maybe -2. We don't want them at +2, +3, +4, where they're combative, pulling at tubes, or we don't want them deeply sedated. And that's easy to do if your patients fit into this category here, where they are compliant, the lung elastance is good, the patient ventilator synchrony is all right. So that's easy to do. However, what we saw in COVID, a lot of our patients were in this group. They had poor compliance, they needed prone positioning, they needed muscle relaxations, they needed ECMO. We really struggled to get those patients oxygenated. So it wasn't possible for us to use the RASS score or any other type of subjective score to measure the depth of sedation. So we were left really with looking at simplified EEG forms. And a simple example of how oversedation happened, this is data from 2 intensive care units, one in Cambridge and one in Italy, looking at patients. And you can see that COVID or non-COVID patients were oversedated. 90% of patients with COVID were oversedated based on a PSI less than 30. And the same thing here, whether they had ARDS or no ARDS, patients were oversedated with a very high incidence of delirium. Now, when you talk about EEG to people, suddenly everyone imagines all these waveforms, and how can I tell all these waveforms while I'm giving an anesthetic? Which is really why the processed EEG was developed, and the processed EEG really took all this raw data from the EEG, used some clever algorithms, a variety of clever algorithms, to come out with simplified number, whether you care to use the DSA here, the burst suppression ratio, PSI, BIS, whatever you choose to do. It made looking at these waveforms a bit more simple, easier to interpret. And I tend to use the Massimo machine. I tend to use SedLine, and SedLine is exemplified here, and it uses a frontal montage that dovetails very nicely with cerebral oximetry and gives you PSI as well as many other parameters. And the way PSI, the patient state index, was developed, it's a sophisticated multivariate algorithm that looks at the patient's EEG from 4 channels, but also have a lot of other contributing factors to it. Okay, and these all come in through a patented algorithm that comes up with either a number here, PSI, 25 to 50 is considered to be the optimal range for sedation and anesthesia. So towards the top bit for sedation, towards the bottom bit for anesthesia. Anything above 50, you're likely to be light, and anything below 25, you're likely to have burst suppression, which means you are too deep. And the reason I use SedLine is because obviously you're putting a frontal montage, and the frontalis muscle, it's got EMG activity, and we know EMG can interfere with the EEG signals. And the beauty of the SedLine is that there is a compensation for EMG. And as you can see here, the new generation SedLine really is not very much affected by EMG. And also you have the ability to see the EMG activity on the screen as you look at SedLine. One other important thing is that as we get older, unfortunately, the power in our brain reduces. And you would think that would reduce the number you get on BIS, for example, and you would use less anesthetic. But that's not the way it works. Unfortunately, that tends to disturb the numbers you get, and those indices sometimes go up. The beauty of SedLine is that the algorithm works throughout the power spectrum, and it's not affected by age. And so you do not have the risk of overdosing elderly patients as you would with other indices. And here's what a comprehensive brain function monitoring like SedLine looks like. You've got the 4 EEG monitors at the top, traces at the top. You've got the PSI, the patient state index, being displayed here in a trend fashion, and a line, and you can see here the patient's too deep, and then the PSI sitting at about 36, 37 over here, and then as they wake up here. And then you have the display, the DSA being displayed at the bottom, right and left, and you can see the symmetry between the two, and it's displayed here as asymmetry signal. And so really, it's a comprehensive monitor. It shows you how well your contacts are, the EEG display, the dial for the EMG, the PSI here, the suppression ratio, and then the DSA, the density spectral assay here, and the difference between right and left in asymmetry graph. And it's very simple, it's like a weather chart: blue, light color, lower power; red, deep color, higher power. And you can see here the frequencies on the side going from the delta, which is 0.5 to 4 hertz, all the way up to the beta, which is 13 to 30 hertz. And every anesthetic tends to have a signature on the DSA. Propofol, for example, is exemplified here. You can see the signal is more intense, around 8 to 12 hertz. You see sevoflurane, higher bands, and the lower bands. You see ketamine, traditional signature up here, and then you see dexamethomidine. And it's not very difficult to get to grips with these signatures very, very quickly. This is an example of propofol induction, maintenance with sevoflurane, and emergence. And you can see the PSI, you can see the EEG, and you can see the ESA behaving as we've already described. These little spectral edge frequencies lines are matched here like train tracks, and as the patient begins to wake up, they start to separate, indicating that the frequency spectral edge is increasing. Oversedation in the ICU has really been worsened by COVID. And again, as I said before, the rationale is that if you're too light, you tend to self-extubate. And I cannot stress enough that oversedation increases the length of stay in ICU, increases mortality, and increases the cost. And this is again showing us that if you assume that a PSI less than 30 is consistent with oversedation, if you assume some burst suppression is consistent with oversedation, the patients in ICU with ARDS, from our experience, have been oversedated. And does everyone that get oversedated get POCD or POD? Of course not. But the evidence now is piling up. It's piling up to show that depth of anesthesia is really important, because there is an increased incidence of delirium with oversedation. There is an increased incidence of POCD with oversedation. Burst suppression is increased incidence of delirium in mechanically ventilated ICU patients, and so on and so on. So the evidence is there that suggests that the least we could do is monitor these patients, even if we don't believe, for example, that burst suppression is linked to delirium or not. If we monitor these patients, we can gauge the level of anesthetic we need to give them in order not to oversedate. And this is an example of where you would think that oversedation is pretty unlikely. A blinded observer study and in patients undergoing procedural colonoscopy as an outpatient. And in 119 patients, 118 of them had a PSI less than 50, consistent with general anesthesia, and a lot of them spent a lot of time with a PSI less than 50, or half the patients spent a PSI less than 50. And interestingly enough, almost a third had a PSI of less than 25, consistent with burst suppression. These are patients that were being sent home a couple of hours after the procedure. And basically, the researcher concluded that depth of sedation achieved with anesthesia administered propofol for colonoscopy spans a continuum. So you cannot predict just by looking at the dose you give. You have to really have some objective measure of brain activity and the effect that propofol is having on that brain. Now, what else results in brain injury? Well, preventing brain injury is all about matching oxygen delivery to oxygen demand. And anything that imbalances the oxygen delivery from being able to meet the oxygen demand causes injury to the brain. For example, alteration in perfusion, reduction in blood flow, perfusion pressure, vasospasm, emboli, anything that alters the actual content of the oxygen inside that blood getting to the brain, saturation, hemoglobin, diffusion, and also anything that increases consumption of oxygen in the brain, such as pyrexia and seizures. And so the brain is very well matched. The blood flow is matched to metabolism. So you get an increase in blood flow when there's an increase in metabolism, and a decrease in blood flow when there's a decrease in metabolism. And when the blood flow exceeds metabolism, you get hyperemia and brain swelling. And when the blood flow is not matching up, to the metabolism, you get ischemia and brain injury. And we have to remember that oxygen delivery is not all about saturation. It's about how much oxygenated blood is getting to that brain. So it's about arterial oxygen content, which depends on the hemoglobin, the oxygen saturation, and slightly the partial pressure of oxygen, but it also depends on cardiac output, which is dependent on the heart rate and stroke volume. And as you deliver less and less oxygen, for whatever reason, the brain extracts more and more oxygen from that blood. So the blood coming out of the venous side has a lower and lower saturation. That is possible up to a point when you reach a critical delivery point, beyond which further extraction is not possible, and you start to develop anaerobic metabolism and ischemia. And cerebral oximetry, measuring cerebral oximetry, is based on that principle. You look at the blood coming back from the brain, or look at the blood inside the tissue of the brain and see how much is the balance between oxygen delivery and oxygen consumption. And it's not new, it's been done for years. And you can use jugular bulb catheters, where you put a jugular bulb, it sits in the jugular bulb foramen. You can use a PO2 probe that you drill a hole and put it inside the brain, as we do, or you can use near infrared spectroscopy like it is with a Massimo or 3 signals. Now, realistically speaking, you're not going to be putting jugular bulb catheters or drilling holes in people's heads undergoing routine elective surgeries such as liver transplant, hip replacement, cardiac surgery. So you're left really with the NIRS monitors. And there's several of them on the market. The one we use, the O3, the Massimo one, has got an emitter and 2 detectors, one shallow and one deep detector, and the wavelengths. We use 4 wavelengths, some systems use 2, some systems use 6. Really, we found that 4 wavelengths with the optimal spacing of the electrodes give us the best signal to noise ratio, which is the most reliable. And the O3 monitor from Massimo is the only monitor that's been calibrated against jugular bulb saturations. And it runs at about absolute accuracy of about 3 to 4% and trend accuracy of about 2 to 3%. So it's a pretty accurate monitor reflecting the changes in the brain. And it assumes that 70% of the blood underneath that sensor is venous and 30% is arterial. And that's how it works out, the calculation. And what you get is you get oxygen tissue saturation here and 3 new indices. The 3 new indices are unique to Massimo. These are the indices that tell you how the saturation is changing. Now, does everyone that drop their oxygen saturation end up having a brain injury? Of course not. But again, there is growing evidence to say that if you desaturate by more than 10% from baseline, you're likely to develop POCD or POD. Here it is, you can see it here, delirium post-cardiac surgery. And it's, you know, cerebral oximetry is a pretty standard of care in most cardiac surgery procedures. Look at this, after orthopedic surgery, even during lumbar plexus block, as opposed to general anesthesia, those who desaturate end up having a higher incidence of POCD. In intensive care, the more time you spend in the lower saturations, the more likely you are to develop delirium. And even post-cardiac arrest, those ones that do not, the survivors tend to push up their regional saturations up to 30 and 40 and 50% very quickly, and they recover. And those that don't at 5 minutes end up not surviving. So there's plenty of evidence now to suggest that changes in cerebral oxygenation are reflective of the way we deliver oxygen to the brain and the way the brain consumes that oxygen. Now, the 3 new indices I told you about earlier on is that they reflect the changes of that hemoglobin underneath that sensor, the hemoglobin mass underneath that sensor. So the saturation in the brain is calculated based on 70% venous and 30% arterial. So the delta CHBI reflects the change in the total blood volume underneath that sensor. So it's venous and arterial. The delta HHB reflects the change in the venous component. So we can tell whether the brain is getting venous congestion, whether there is increasing hypoxia, whether there is venous obstruction. And the delta O2HBI reflects the change in arterial component of the blood volume. So the changes in blood volume, hyperemia, vasodilatation, higher. So now we're able to see when the saturation in the brain changes, what is causing that change in saturation? Is it a drop in the arterial supply? Is it an increase in venous congestion? Is it an increase in total blood volume? Is it an increase in consumption? So the clinician now, not only does he look at the saturation and say there's an increase or a drop in saturation, but then now they're able to say what is likely to be the cause of that desaturation and act accordingly. Here's an example of techniques we used during COVID to improve systemic oxygenation, but we forgot about the brain in a lot of those patients. And you can see here, this paper published recently in Critical Care Medicine, that when you use a recruitment maneuver, you don't really have much of an effect on the systemic oxygenation, but you worsen brain oxygenation. When you look at carbon dioxide removal systems, again, you drop you worsen not only systemic oxygen, but brain oxygenation gets a lot worse. When you use a prone position, you improve oxygenation systemically and the brain, and the same thing with nitric oxide. And it's good to see that now we're looking not only at the way we improve systemic oxygenation, because the ultimate aim of improving systemic oxygenation is to deliver more oxygen to the vital organs. And now with the ability to monitor the brain with cerebral oximetry, you can actually visibly see the changes in the vital organs of interest. Another thing that we use for near-infrared spectroscopy for, or oximetry for, is to look at autoregulation. And traditionally, autoregulation with cerebral autoregulation is measured either by using transcranial Doppler or some more invasive techniques. And now we have a system called ICM Plus, where we continuously monitor autoregulation, and we look at PRX from the ICP bolt and the changes in perfusion pressure. And you can see here that by using near infrared spectroscopy, the O3 signal, we're able to see that we can pretty much get an indication of how autoregulation is doing when it comes to changes in perfusion pressure. The trouble with it is not perfect. And the reason it's not perfect is, as I said before, the signal, the saturation signal is 70% venous and 30% arterial. And therefore, there's a lot of contamination from the venous side, which we know does not take part in the cerebral autoregulatory mechanism. And this is how we looked at that. When we dissected that and looked at the actual changes in the delta HB, you can see here against transcranial Doppler, looking at the venous component changes with changes in perfusion pressure, there's really no correlation. The saturation, there is a little bit of a correlation, but look at this perfect correlation. When you isolate the arterial component, which is the delta HbO2, you can see that it pretty much matches the changes you see on transcranial Doppler in terms of assessing autoregulation. And that's why we think it is pretty unique to the O3 signal provided by Massimo. When you combine cerebral oximetry with SedLine, you get a real picture of metabolism as well as oxygenation. So here, the traditional O3, the first generation is, just gave you saturation, whereas this one here gives you saturation, the changes in deoxygenated hemoglobin, oxygenated hemoglobin, and total hemoglobin. So you can see in this patient here, consumption has gone up because the total blood volume hasn't increased, but there's an increase in deoxygenated stuff and decrease in the arterial stuff. So here, no changes in the total volume. The change must have been because the brain is consuming more oxygen. And when you combine that with the SedLine here, you can see that PSI has gone up to 84%. So the patient suddenly lightened, woken up, and as they did, oxygen consumption increased, and the blood flow to the brain hasn't matched to it, and so you see the desaturation. And obviously, the treatment for that was increasing the level of sedation and pushing the patient back to sleep. Again, if you look at this case here, really not much change in the saturation in the brain, but the brain was going into burst suppression. You see these dark lines with the blue tip indicate burst suppression. So the patient was going into burst suppression. Is this increased depth of anesthesia? What's going on here? When you look at these signals, you see that the deoxygenated hemoglobin and the oxygenated hemoglobin have dropped down. So what was happening here was that the oxygen delivery to the brain is reduced. What could be the cause of that? And we look at the hemoglobin, it's dropped from 139 to 83. So the actual oxygen we were delivering to that brain has reduced. So this alone would have given you the impression that anesthesia was too deep. This alone would have given you the impression that everything was okay. You combine them together and you get to the idea that actually this patient was bleeding. That's why the blood flow reduced. That's why oxygen delivery to the brain reduced. And that's why he went into burst suppression. Now, the beauty of regional oximetry is that you can use it for other sites other than just the brain. And it's great. You can put it on the back, you can put it on the legs, you can put it on the abdomen in small children. And so what happens? What can you do with that information? And when you look at the vital organs, the brain is very protected, so you tend not to divert the blood flow from the brain until a last resort. Now, regional oximetry now is being used in neonates to look at the compromise in vascular compromise, and mesenteric desaturations, looking at enterocolitis, necrotizing enterocolitis in neonates, using it as an indicator of renal blood flow after cardiopulmonary bypass can tell us about how well those peripheral, less vital organs in the brain have been affected. Nevertheless, vital organs, but less vital in the brain. And then you can see, for example, the changes between renal oxygenation, cerebral oxygenation, and how that can relate to the development of lactic acidosis. And reconstructive plastic surgery in trauma of compartment syndrome, we now have evidence to suggest that vascular flaps, for example, can be monitored non-invasively with NIRS and have a higher salvage rate of about 89% when you use it, compared with about 50% when the flaps are monitored by clinically alone or using Doppler, because that only looks at the arterial side, but NIRS would look at the entire component. And here's an example of looking at cerebral oxygenation as well as somatic, looking at the kidney. You've got the brain here at the top trace, 68%. This here, the kidney is 82%. This is in a neonate undergoing pulmonary stenosis surgery, pulmonary artery stenosis. And you can see they got in trouble here. So the saturation, systemic desaturation drops and cerebral desaturation drops. But the renal side is not affected that much because the kidney doesn't consume as much oxygen as the brain. And you can see what's happening here. The oxygenated hemoglobin is dropping. The oxygenated hemoglobin is staying the same. And you can see that the changes here are really, really dangerous for a child. So as soon as you get on bypass, you improve the systemic circulation and the oxygenation, you suddenly have an increase in brain oxygenation with a rapid increase in the oxygenated hemoglobin being delivered. And in fact, some of that is being taken away from the kidney. So the kidney drops a little bit more, but it doesn't seem to be too affected with the as reflected by the saturation. Again, because it has a lower metabolic rate under anesthesia. And then at the end of the procedure, most things go back to normal. And you can see how this can help the anesthesiologist and even the cardiac surgeon determine what needs to be done next. So if you can't improve oxygen delivery, you got to reduce oxygen consumption because it's a balance between the two. And can we do this? Sedation, getting it right. Temperature control and preventing seizures. We know that in traumatic brain injury, 20% of those patients got non-convulsive seizures, and seizures consume oxygen. We know that maybe hypothermia doesn't reduce oxygen consumption, but hypothermia really burns up the oxygen consumption. So if we use SedLine and O3, we can optimize sedation, we can avoid over-sedation, reduce oxygen consumption, we can use muscle relaxants, we can reduce myocardial depression, and we can detect seizures and prevent hyperpyrexia. So the question I want to leave you with is it's no longer sensible to say, why would I monitor the brain in my patients? But the question has to be, why wouldn't I monitor the brain in my patients? You know, because it's a non-invasive technique. It may not give you all the information you require in every patient, but it will give you a lot more information than you have if you didn't monitor. So rather than flying blind now, we have the ability to look at the physiologic changes going inside the brain in terms of metabolism as reflected by the EEG, in terms of oxygen consumption as reflected by O3. And you know, imagine you undergoing anesthesia or sedation in critical care. Really, wouldn't you want your brain monitored? We have to optimize patient care and ensure brain well-being. We really do, because if it would be a tragedy if you recover from a severe illness such as COVID-19 only to find yourself nursing a brain injury. And I just want to leave something in your mind. People always talk about cost benefit. Now there are 400 billion car journeys in the US every year, 400 billion, but only 6 million car accidents. That is less than 0.001% incidence of car accident, but everyone wears a seatbelt. And so we need to start thinking along those lines. You don't know which brain is at risk until it gets injured. And it's our duty to make sure we do the best we can to keep those brains protected. Once again, thank you very much for listening, and I hope you have a successful meeting.
The human brain is one of the most important organs in the body. As the control center for movement, thought, memory, and emotion, it shapes who we are and how we experience the world. That's why protecting this vital organ is critical before, during, and after surgery, especially for older patients. At Masimo, we share your commitment to patient safety and offer advanced, non-invasive monitoring technologies that increase the amount of data available to you on patient brain function and oxygenation, helping you provide balanced anesthesia to your patients during surgery and empowering you with actionable information at critical moments. Next Generation SedLine monitors the effects of anesthesia on the brain through bilateral data acquisition, using 4 channels of frontal EEG waveforms to monitor both brain hemispheres together in real time. Alongside sedation monitoring, O3 regional oximetry offers continuous, accurate monitoring of absolute and trended regional hemoglobin oxygen saturation and can be used on all patient populations. Both Next Generation SedLine and O3 regional oximetry feature ergonomically designed sensors that may be worn comfortably at the same time. Root, a versatile patient monitoring and connectivity hub, brings these 2 powerful technologies together, providing a valuable method of viewing and interpreting key patient data on a single screen. Using these synergistic modalities simultaneously is gaining popularity among anesthesiologists, as the combination of EEG and near-infrared spectroscopy may offer more insight into a patient's brain activity. As an added benefit, the Root platform offers powerful automation features, including built-in network connectivity, third-party device integration, and automatic data transfer to the EMR, helping reduce the equipment footprint in the OR and ICU and streamlining care team workflows. With greater convenience and more data, you can focus on what matters most, delivering excellent patient care and improving patient outcomes. Discover a more complete picture of the brain with Masimo Brain Monitoring Solutions.
Nihon Koden has developed a new technology to monitor cardiac output non-invasively and continuously. ESCCO is a new parameter which is calculated from the common vital sign parameters ECG, SpO2 pulse wave, and blood pressure. Currently, there are several clinical methods of measuring cardiac output, such as the pulse contour method, the Doppler method, thermodilution with pulmonary artery catheter, and echocardiography. ESCCO is a new method of measuring cardiac output non-invasively and continuously by using common vital sign parameters based on the pulse contour method. ESCCO is based on the inverse correlation between pulse wave transit time and stroke volume. Pulse wave transit time is the time from the ECG R wave peak to the pulse wave rise point. Pulse wave transit time is calculated from ECG and SpO2 pulse waves at the fingertip. This inverse correlation has been confirmed by many experiments and data analysis and has been shown to be unaffected by administration of drugs, including vascular agents. Based on this correlation, ESCCO is derived by a unique formula. The accuracy of ESCCO has been validated in clinical studies, and the accuracy and trending performance have been shown to be acceptable for clinical use. Currently, there are ongoing clinical evaluations of ESCCO to further improve the performance.
私たちはそのスワンガンズカテーテルあるいはフロートラックといった侵襲性のあるモニターを使ってまいりました。このために循環系にリスクのある方あるいはリスクの高い手術といった限られた症例でしか経験を積んでこなかったんですね。ところがこの ESCC を用いることによって誰でもいつでも心拍数あるいは1回拍数をモニターすることが可能となりました。その結果、普段起こっている血圧の変動というのが 一体何によって起こったのか、心臓の収縮力が低下したのか、血管が開いたのか、あるいは循環血流が少ないのかといったその3つの因子が常に診断されながら循環管理ができるという非常に特殊なことが可能となりました。
By allowing cardiac output to be monitored with basic parameters, ESCCO enables safe, effective, and efficient hemodynamic management in various clinical applications.
Nihon Koden offers an optimal solution for respiratory monitoring during resuscitation and sedation. Reliable monitoring of ventilatory status can be achieved with CAP1 capnography technology, the world's first mainstream CO2 sensor, which is specifically designed for both intubated and non-intubated patients. Continuous waveform capnography during resuscitation is recommended by the AHA guidelines. Are you monitoring expired CO2 during resuscitation? Capnography has been the standard of care for monitoring adequacy of ventilation during anesthesia in the OR and ICU. Nowadays, clinical importance of waveform capnography is growing as a way of safer respiratory management in the ER. During resuscitation, continuous waveform capnography provided by CAP1 can reduce the risk of potential complications and improve the quality of CPR. AHA guidelines recommend capnography for increasing the safety of airway control and ventilation. The CAP1 CO2 sensor can easily switch its attachment from mask to tracheal tube and help you to reduce complications such as tube misplacement or displacement. The 2010 AHA guidelines also recommend capnography as a physiological monitor of the effectiveness of chest compressions. CAP1 waveforms will give adequate feedback of chest compressions and help optimize the quality of CPR. Furthermore, CAP1 technology, which has rapid responsiveness to a change in expired CO2, is a useful tool to promptly detect the return of spontaneous circulation. This is CAP1, a new class of ultra-compact CO2 sensors. CAP1 overcomes the disadvantages and retains all the advantages of conventional mainstream CO2 sensors. By using advanced miniaturization and leading-edge sensor technology, the CAP1 sensor has achieved an extremely light and small size. CAP1 weighs only 4 grams and the dead space is less than 1 milliliter. CAP1 is as small and handy as sidestream CO2 sensors and can be used without dealing with issues of additional weight and dead space on airways. CAP1 meets IPX7 waterproof standards and is impact resistant. A satisfactory capnography performance is promised by CAP1 in harsh environments such as outdoor emergency care. CAP1 has a unique design with just a light source, a half mirror, and 2 photodetectors. Neither a motor nor a heater is required. With this unique structure, CAP1 realizes accurate and reliable measurement without being affected by humidity or secretion in the airway. Another innovative feature of CAP1 is the use of an original transparent film with anti-fogging membrane. The anti-fogging membrane forms a smooth layer of water which allows stable transmission of infrared light without irregular reflection. This technology eliminates the need of heaters and leads to reducing power consumption and weight of the CAP1 sensor. This experiment demonstrates the excellent performance of the anti-fogging membrane. You can see that the anti-fogging coated membrane is not affected by moisture. Advantages of mainstream sensors are rapid response, less waveform distortion, and few measurement interruptions. But compared to side-stream sensors, mainstream sensors are heavier, limited to intubated patients, and have larger dead space. But now CAP1 has overcome these disadvantages and maintains all the advantages of the mainstream sensor for the optimal capnography. The CAP1 mainstream capnography is the best choice for safe, accurate, and reliable CO2 monitoring during resuscitation and ensures advanced airway management and high-quality CPR. Sedation of pediatric patients is associated with risk of adverse respiratory events. Nihon Koden offers a new solution for respiratory monitoring to increase safety of pediatric patients during sedation. This is CAP1 mask. The CAP1 sensor can be attached to the original oxygen mask. This unique open-face feature allows to reliably detect both oral and nasal expiration and provide a gentle stream of oxygen at the same time. The expired CO2 from both nose and mouth is guided to reach the CO2 sensor by the unique form of CAP1 mask, and the patient's respiration is accurately detected without delay. Excess expired gas flows out from the widely open area to prevent retention of the expired gas within the mask. Our experiments show that with the CAP1 mask, a high-quality capnography waveform can be obtained from both oral and nasal expiration without being interrupted by administered oxygen flow. Oxygen provided from both sides of the mask goes through a diffusing plate, then is well dispersed in the mask. Oxygen can be supplied to a patient effectively and efficiently with little discomfort. Compared to a conventional oxygen mask, CAP1 mask can provide a patient with a constant and higher concentration of oxygen. With CAP1 mask, CO2 can be continuously monitored during oxygen administration. For non-intubated adult patients, another unique CAP1 sensor catches both oral and nasal expiration. All the Nihon Koden CAP1 sensors are designed to be easily switched from intubated to non-intubated patients. The CAP1 provides reliable and continuous respiratory monitoring and ensures the quality of care under sedation. By overcoming all the disadvantages of mainstream sensors, but maintaining advantages for the optimal capnography, CAP1 provides high-quality CO2 monitoring for both intubated and non-intubated patients in various clinical settings. CAP1, a safe and accurate capnography during resuscitation and sedation. Nihon Koden opens the new era of capnography with CAP1.
For any inquiries with regards to Dr. Mata's topic, you may send it through the chat box in our virtual booth, Variance Trading Corporation.